Respected Emeritus Chairperson, Mahatma Gandhi University of Medical Sciences and Technology, Dr. M.S. Shankar sir, Chairperson cum Chancellor, Dr. Vikas Chandra Swankar, Vice Chancellor, Dr. H.R. Gulati, Pro Vice Chancellor, Dr. V.K. Kapoor, Principal, Dean Principal, Mahatma Gandhi Medical College Hospital, Dr. N.D. Soni, Senior Faculty Members, colleagues and dear students. I, Dr. Tarun Ojha, welcome you all to the 9th Undergraduate Combined Rounds of Mahatma Gandhi Medical College and Hospital, Jaipur. Today's topic for UGCR is hypertension. As it's an important topic, so we all should learn about it. We have divided it into two parts. Part 1 would consist of anatomy, physiology, pharmacology, and pathological aspects of hypertension. And part 2 would deal with clinical features, management, and prevention of hypertension. Today's chairperson for the session are Dr. Raman Sharma, Dr. Deepesh Agarwal, Dr. Raman Sinha, Dr. Manju Raghav. This presentation is prepared by our undergraduate students under the guidance of subject HOD and moderator and reviewed by the Board of Review. So, appreciate and bless our undergraduate students for their presentation. Now I would request Dr. Deepesh Agarwal to introduce hypertension to all of us.
Thank you, sir. First of all, I would like to say thanks and good morning, respected dignitaries. So, blood pressure probably is the most important topic, and one of our family members is suffering from high blood pressure. So, I have one question to all. How many of you know your blood pressure? And how many of you know your family's parents or grandparents' blood pressure? So, less than 50%, even I think 30-40%. So, worldwide data, prevalence of hypertension is around 30%. In adult means more than 18 years of age people. And the worst part is, those 30% patients, those who are diagnosed with high blood pressure, they don't want to accept that they have high blood pressure. And why it is important? Because keeping a blood pressure high will lead to many complications starting from head to toes. That means the complication can start from brain. You may have paralysis, stroke, then it involves eyes, loss of vision, and then kidneys. Most common cause of kidney failure is high blood pressure, that is undiagnosed, untreated. And then your heart failure and heart attack, and limb ischemia leading to amputation of limb. So keeping high blood pressure probably is most dangerous part, and treating this and prevention of this is very important. So in MBBS curriculum, probably we should know what are the conditions and how blood pressure maintained in our body, either low or high. So for hypertension control, probably brain, autonomic nervous system play an important role, that is anatomical feature, and kidney plays an important role by secreting hormones like renin, angiotensin and aldosterone system that regulate your blood pressure. And with this knowledge, if you have knowledge of how blood pressure maintained, you can treat your patient accordingly by drug giving, acting on system according to that. Then there are a number of conditions where you may have high blood pressure because of your own reasons, like many drugs, over-the-counter drugs available in the market like NSAIDs, painkiller. Many of the patients or even normal person, they used to take continuous painkiller for knee pain and other things. Like steroids, oral contraceptive pills, anti-cancer drugs. These are common drugs which usually took by the patient, and they don't tell that we are taking these drugs. Because of that only patient may have high blood pressure. So number one important is to know your blood pressure, your family blood pressure, and then what is the classification of blood pressure. I'll tell you in 2-3 words more. So we are having high blood pressure definition of 140 and 90 or more than that is classified as high blood pressure. Now this is important, this is office blood pressure. When a person comes to in OPD, patient may not have this kind of blood pressure at home. So important is more than that, most of the time a person spends their life at home or at office, and that blood pressure is important for long-term complications. So at home blood pressure, the reading is 135/85 or more. So second, and third is ambulatory blood pressure, where you measure your blood pressure in morning, evening and night also. So for office blood pressure and home monitoring blood pressure, we usually do blood pressure in the morning hours or daytime hours, but about night time blood pressure. So for that blood pressure, you need to check your blood pressure in 24 hours period. That is classified as ambulatory blood pressure monitoring. And for that ambulatory blood pressure monitoring, 130 and 90 millimeter mercury is basically, or above this is classified as high blood pressure. So for blood pressure classification, there are three methods. One is office blood pressure, that is 140 and 90. Home blood pressure monitoring, average blood pressure if it is more than 135 and 85. And 24-hour ambulatory blood pressure monitoring, where it reads daytime and nighttime blood pressure. If it is more than 130 and 80, that is classified as high blood pressure. Now, why it is important? Hypertension is one thing which is probably misdiagnosed and mistreated, both overdiagnosed and underdiagnosed. Now, many a times patient comes to your office that is transiently or momentarily they have high blood pressure, that is called as white coat hypertension. Just by the sight of the hospital, at the time of doctor diagnosis or measurement, they may have transient high blood pressure, and other time they may have normal blood pressure. Now this is important. If you treat these patients, they are over-treated patients. Similarly, if patient comes to you and if they don't want to accept, or in the hospital they have normal blood pressure, but at workplace or at home they have high blood pressure, they are classified as masked hypertension, that is undiagnosed hypertension. Now both conditions occurs, almost 30% of patients they are suffering from either white coat hypertension or masked hypertension. So overdiagnosis, overtreatment, and underdiagnosis, undertreatment, both are common. So I think these all will be discussed in detail in anatomical, physiology and pathological aspect, and in next lecture probably in medical aspect. Thank you very much. Thank you.
Good morning, dignitaries, esteemed faculty members and my fellow colleagues. Today, under the guidance of Dr. Pankaj Kumar Singh Sir, Professor and Head Department of Anatomy, under the moderatorship of Dr. Runjun Vijayvargiya Ma'am and Dr. Abhilasha Maharishi Ma'am, alongside Ananya Joshi, Mokshi Ramrakhani, Saksham Modi, Vinayak Omkarka, I, Divyanshi Singh, would like to present on the topic Hypertension, the Anatomy of Cardiovascular System. Before we dive deep into the anatomy, it is essential for us to understand what exactly is hypertension. Now, hypertension is defined as the persistent elevation of blood pressure within the arteries, with the systolic blood pressure tending to remain more than or equal to 140 millimeters of mercury, and the diastolic blood pressure tending to remain more than or equal to 90 millimeters of mercury. The cardiovascular system. Blood pressure is defined as the product of cardiac output and total peripheral resistance. The cardiac output correlates it to the heart, its structure and functioning, while the total peripheral resistance correlates it to the structure and functioning of the vessels of the body. Hence, as the name suggests, the cardiovascular system comprises the heart and the vessels of the body. Let us now take a look at the anatomical aspects, starting off with the anatomy of heart. The heart lies in the middle inferior mediastinum, directed slightly towards the left. It consists of 4 chambers, the upper 2 smaller chambers, the right and the left atrium, and the lower 2 larger chambers, the right and the left ventricles, separated by the tricuspid and bicuspid walls respectively. Morphologically, the heart also presents the superior and inferior vena cava, the arch of aorta, and the pulmonary trunk. The heart has 3 surfaces, the anterior or sternocostal surface, the inferior or diaphragmatic surface, and the left surface. It has 4 borders, the superior border, the inferior border, the right border, and the left border. It presents an apex formed entirely by the left ventricles and a base formed by the right and the left atrium. Now we know that the heart pumps blood to the entire body, but it is crucial for us to know the blood supply to the heart itself, which is referred to as the coronary circulation, comprising of the 2 coronary arteries and their main branches, the right coronary artery and the left coronary artery. The right coronary artery arises from the anterior aortic sinus of the ascending aorta. It descends anteriorly in the coronary sulcus, giving off two branches. Moving posteriorly, it gives off the posterior interventricular artery, which runs in the posterior interventricular sulcus. The posterior interventricular artery is responsible for determining the cardiac dominance. The left coronary artery arises from the left posterior aortic sinus of the ascending aorta. It descends anteriorly, giving off two branches, the circumflex branch and the anterior interventricular artery, otherwise known as the left anterior descending artery, which runs in the anterior interventricular sulcus. Moving posteriorly, it gives off another branch and finally terminates by anastomosing with the corresponding right coronary artery. Equally important to the arterial supply of the heart is the venous drainage of the heart, done mainly by the three cardiac veins: the great cardiac vein, the middle cardiac vein, and the small cardiac vein. The great cardiac vein follows the path of the anterior interventricular artery. The middle cardiac vein follows the path of the posterior interventricular artery, and the small cardiac vein follows the path of the right marginal artery. All the three cardiac veins ultimately drain into the coronary sinus, while the anterior cardiac veins drain directly into the right atrium, and the vena portis minimi drain into the endocardium of all the four chambers of the heart. There are three different types of vessels in the human body: the arteries carrying blood from the heart, the veins carrying blood to the heart, and the capillaries. Since our topic of discussion for today is hypertension, we shift our focus primarily to the arteries and their classification. Arteries can be classified into three different types based on their size and structure, namely the elastic arteries, the muscular arteries, and the arterioles, with their diameters decreasing in the same respective order. Anatomy of a vessel. A blood vessel wall consists of three layers: the tunica intima, the innermost layer, the tunica media, the middle layer, and the tunica externa or adventitia, the outermost layer. Let us take a look at the histology of these arteries, starting with the elastic artery. The innermost layer, tunica intima, is composed of a thin endothelial layer surrounded by the subendothelial connective tissue, which is thick and well defined. Distinguishing the tunica intima and tunica media, we have the internal elastic lamina, which is not well differentiated. The tunica media is composed of smooth muscle fibers and elastic fibers, with the elastic fibers largely outnumbering the smooth muscle fibers. The tunica adventitia is thin with numerous vasa vasorum. Examples of elastic arteries are the aorta and the pulmonary arteries. Muscular artery. Surrounding the thin endothelial layer, we have the subendothelial connective tissue, which is almost negligible. Distinguishing the tunica intima from the tunica media, we have the internal elastic lamina, which is well defined, in contrast to the elastic arteries. The tunica media is composed of smooth muscle fibers and elastic fibers, but this time the smooth muscle fibers largely outnumber the elastic fibers. The tunica adventitia is composed of collagen and elastin fibers. Lastly, we have the arterioles. The thin endothelial layer is surrounded by the subendothelial connective tissue, which is less, negligible, or absent. The internal elastic lamina is present in larger arterioles, but it may be absent in smaller arterioles. The tunica media is majorly composed of smooth muscle fibers, and the tunica adventitia is thin or may be absent. Other extremely important vascular structures related to hypertension are the meta-arterioles and pre-capillary arteriovenous anastomosis, otherwise known as the thoroughfare channels or the preferential channels. The meta-arterioles serve as vascular shunts when pre-capillary sphincters are closed, while the thoroughfare channels allow the blood to bypass the capillary beds and enter directly into the venules. The thoroughfare channels are found in many different organs such as skin, lungs, heart, intestines, etc. Nerve supply of vessels. Mainly by the sympathetic nervous system, a single sympathetic nerve fiber innervating a vessel on application of a stronger sympathetic tone leads to smooth muscle contraction and hence vasoconstriction, whereas on application of a weaker sympathetic tone leads to smooth muscle relaxation and hence vasodilation. Complications of hypertension may further include brain aneurysm and hence brain stroke, left ventricular hypertrophy and hence cardiac arrest, kidney scarring and hence kidney failure, and retinal hemorrhage and hence visual impairment. Let us take a brief look at the etiology behind hypertension. First, arteriosclerosis. It refers to the hardening of the arteries, due to which there is loss of elasticity in the walls of the arteries. It usually affects small arteries and arterioles. It can have several different causes. Atherosclerosis. A type of arteriosclerosis. Atherosclerosis is a chronic inflammatory disease of the arteries, principally a lipid-driven process due to the accumulation of low-density lipoprotein and remnant lipoprotein particles in the walls of the vessel, leading to the formation of an atherosclerotic plaque in the vessel wall. It usually affects medium and large-sized arteries. Coarctation of aorta. An embryological condition, although rare, it can lead to hypertension because of the narrowing of the aorta beyond the origin of the left subclavian artery. However, it can occur in several different locations such as the thoracic and the abdominal aorta. On the basis of the position of the ductus arteriosus, there are three types of coarctation: preductal, ductal, and postductal, with postductal being the most common type of coarctation. Here are a few references. I'd now like to invite Mehal Jain to represent the Department of Physiology.
Good morning, esteemed dignitaries, respected faculty members, and my fellow colleagues. I, Mehal Jain, along with the help of my group members, Sanskar S. Ratnawat, Shaurya Lekhra, Manaswini Sharma, and Raghavendra Singh Rathore, am here to present on the topic Hemodynamics of Cardiovascular System. This presentation was formed under the guidance of Dr. Aparna Garg and moderatorship of Dr. Anita Jain and Dr. Rosie Paul. With approximately 30% of adults in urban areas and 25% in rural areas living with hypertension, a deeper understanding of the underlying physiology is imperative. Hence, we aim to fulfill the following objectives, including the basic principles of hemodynamics and velocity flow pressure relation in blood vessels, different types of blood flow, factors affecting peripheral resistance, laws governing hemodynamics, blood pressure, regulatory mechanisms, and physiological variations and clinical applications. Hemodynamics is a term denoted to the interaction of various physical principles that control the circulation of blood in the human body. Before understanding hemodynamics in detail, here is a brief overview of blood circulation in our body. Blood flows from heart to the arteries and arterioles, thence to capillaries, and eventually to venules, major veins, and back to the heart. Each segment of vasculature has specific contractile properties and regulatory mechanisms that subserve physiologic function. The primary principle behind hemodynamics is the velocity-pressure-flow relationship. It encompasses two subparts. First is the relationship between velocity and blood flow. While velocity is the rate of displacement of fluid with respect to time, flow is a term which denotes the volume displaced per unit time. The direct proportionality between velocity and blood flow is accounted for by the inverse relationship between velocity and cross-sectional area as shown in the first graph here. The other major relation is between velocity and pressure. This correlation is explained by the Bernoulli's principle, which states that the total pressure in a closed system remains constant. This mathematical expression states that in a supine position, when the effect of gravity and hydrostatic pressure is removed, the E of the flowing blood in the vessel is the lateral pressure added to half the density and square of velocity of blood flowing through the vessel. Kinetic energy is the energy gained by the body due to its mass and velocity, whereas potential energy is the energy that is stored in a body and can be used to do work. Potential energy is the key factor in the movement of blood through the circulatory system. Variations in these principles bring about different types of blood flow in our body. Laminar flow, where the flow is streamlined, paired, layered, parallel, and uncrossed. This is the normal pattern of flow which follows the Poisson's law, that is, it's below the critical velocity. This will be discussed further in our presentation. Furthermore, it is soundless and highly efficient. When the Reynolds number or RE is below 2000, the flow is laminar. Whereas when it is more than 2000, the flow is turbulent, which is a disturbed, unlayered, and cross type of flow. The Reynolds number in equation helps predict the likelihood of turbulence in blood vessel. Unlike laminar, turbulent flow is associated with sound. It does not follow the Poisson's law, that is, it's above the critical velocity and it's comparatively inefficient. Another major determinant of hemodynamics is the peripheral resistance, which is the resistance offered to the flow of blood in peripheral circulation. It is governed by multiple cardiovascular regulatory mechanisms existing in our body. They include the primary determinant, which is the blood vessel diameter, along with blood viscosity, flow resistance, and autonomic activity. Radius of blood vessel affects peripheral resistance. This is called vascular hindrance. Vasoconstriction increases and vasodilation decreases peripheral resistance. Viscosity of blood also affects peripheral resistance. This is called hematological hindrance. Viscosity mainly depends on factors like hematocrit, concentration of plasma, especially the plasma proteins, resistance of red blood cells to deformation, and temperature. Hematocrit is the volume percentage of red blood cells in the blood. The relationship between viscosity and hematocrit is linear. A 1 unit increase in hematocrit can cause a 4% increase in the blood viscosity. Furthermore, flow resistance also affects peripheral resistance. RBCs increase flow resistance by rubbing up against the vessel wall. They travel through capillaries measuring only 5 micrometers in diameter, despite their average diameter being 8 micrometers in diameter. They readily distort, allowing them to slip through narrow vessels. Additionally, RBCs travel in the center of the vessel, which minimizes interaction with the endothelium. Autonomic activity is one of the factors that control peripheral resistance during high sympathetic activity. It constricts peripheral vessels, which increases the peripheral resistance, raising heart rate higher than the intrinsic rate to meet increased demands. Certain laws govern the flow of blood in the circulatory system, namely the hemodynamic laws. The Poisson's law. Given here is the Poisson-Huygens formula, which denotes the relationship between viscosity of the fluid with the radius and length of the tube. Here, Q1 and Q2 denotes the blood flow at the non-compressed and compressed ends respectively. On vasoconstriction, BP is markedly increased, whereas on vasodilation it is decreased. The flow becomes double in a vessel just by increasing the radius to about 20%. Flow affects the pressure, and hence the change in diameter changes the flow and pressure. Reduction in the flow of blood and conversion of pulsatile blood flow to the steady continuous flow is all under the effects of Poisson's law. Another very important application of this is the Van-Diesel effect, in which the elastic properties of large arteries buffer the changes in blood pressure and flow during the cardiac cycle, as seen in the proximal aorta here. The law of Laplace explains the relationship between distending pressure, tension in the wall, and radius. Presented here is the formula demonstrated by this law, where R1 and R2 are its two principal radii of curvature. So in a small diameter blood vessel, less wall tension is required to balance the distending pressure. This protects small vessels from rupture. This comes into application when the organs get filled or the cavity size increases, causing the wall tension to consequently increase. Additionally, when the wall thickness is more, the wall tension decreases. Blood pressure is the lateral pressure exerted by the flow of the blood on the vessel wall. There are 4 categories of blood pressures with clinical importance. Firstly, there is systolic blood pressure, which is the maximum pressure exerted during the contraction of ventricles. Next is the diastolic blood pressure, which is the minimum pressure recorded just prior to the next contraction. Pulse pressure is the difference of systolic and diastolic blood pressure, whereas mean arterial blood pressure is the average pressure of blood in the arteries during a cardiac cycle or heartbeat. These are the images of digital, aneroid and mercury type of sphygmomanometers that are used to measure the blood pressure. Given here is a classification according to the 8th Joint National Commission's 2017 hypertensive guidelines of blood pressure, including systolic and diastolic blood pressures respectively. The normal range of systolic BP is 110 to 119 mmHg, whereas diastolic BP is 60 to 79 mmHg. Also given here are the values of pre-hypertension, hypertension stage 1 and 2, and hypertensive crisis. Now, let's get a brief on the normal physiological mechanisms which help maintain the blood pressure. There are different reflexes responsible for the regulation of blood pressure. The short-term regulatory mechanism, which includes the baroreceptor mechanisms, chemoreceptor mechanisms, and the CNS ischemic response. Furthermore, there is intermediate regulatory mechanisms which include capillary fluid shift and stress relaxation mechanisms. Furthermore, there is long-term regulatory mechanisms which has 2 parts, that is renal and hormonal. Firstly, the baroreceptor reflex. An increasing or falling blood pressure causes varying degree of stretch in the carotid sinus, which causes the activation of baroreceptors, which causes varying degree of stimulation to the nucleus tractus solitarius. This further acts on the vagus nerve and the vasomotor center, which brings about changes to counter the initial stimulus and maintain homeostasis. Next is the chemoreceptor reflex. Chemoreceptors monitor local metabolite levels. Chemical changes stimulate the chemoreceptors, namely the carotid body and the aortic body, from which the impulse is carried further to the respiratory center in the medulla. Effluents from these centers are capable of inducing various physiological changes such as vasoconstriction, tachycardia, and bradycardia depending on the variety of the stimulus. This type of short-term regulation, also known as the Cushing's response, is seen in the cases of gross hypotension as seen in acute severe hemorrhage. Decreased cerebral blood flow leads to the deficiency of oxygen at the cardiac or vasomotor centers in the medulla, causing stimulation. This leads to intense vasoconstriction, so the blood flow to the vital organs is maintained. Furthermore, it is activated when there is a steep fall in the blood pressure. This is the last physiological reflex to control BP. Intermediate regulation of blood pressure. It is another type of regulatory mechanism. It consists of 2 mechanisms. First is the capillary fluid shift mechanism, which occurs when there is a change in BP due to changes in the blood volume. Hydrostatic pressure inside these vessels changes, leading to flow of the fluid either in or out of the vessels. This flow of the fluid helps in normalizing the blood pressure. Stress relaxation mechanisms also regulate BP. The changes in the flow of blood is sensed by the smooth muscle walls of the blood vessels. This leads to either the relaxation or contraction of vessels, thus normalizing the blood pressure as shown in the given flow chart. The long-term regulation mechanism has interconnected renal and hormonal subdivisions. Kidney controls the blood pressure by controlling the urinary excretion of salts and water. Its ability to retain water is controlled by the anti-diuretic hormone released from the posterior pituitary. Retention of sodium is locally controlled. The renin-angiotensin system is a key regulator of blood pressure and fluid balance. It begins when the kidney releases an enzyme called renin, which converts the angiotensinogen to angiotensin 1. Furthermore, the angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme. Angiotensin 2 is a powerful molecule that constricts blood vessels and prompts the release of aldosterone. This process increases the blood pressure and helps retain sodium and water in the kidneys. Sodium and water retention increases circulating blood volume and helps in normalizing the blood flow and thus the blood pressure. Blood pressure is the product of cardiac output and peripheral resistance. There are certain determinants of blood pressure, including primarily the heart rate, which is defined as the number of contractions per minute. Furthermore, cardiac output is defined as the result of stroke volume and heart rate. This stroke volume is an important determinant which is the end diastolic volume subtracted by the end systolic volume. Furthermore, the end diastolic volume is directly proportional to the preload. Thus, any alteration in the preload elicits change in the end diastolic volume, altering the stroke volume and ultimately the blood pressure. Afterload also affects the myocardial contractility, therefore having an effect on the blood pressure. Next are some physiological factors that affect the blood pressure. The first crucial factor is age. Blood pressure tends to increase with age due to stiffer arteries and changes in heart and kidney function. Next is gender. Men often have higher blood pressure than women until menopause, after which women may experience higher readings. Furthermore, eating affects blood pressure as high salt intakes and large meals also raise the blood pressure while a balanced diet helps regulate it. Sleep is another factor. Poor or insufficient sleep can lead to elevated blood pressure due to stress and hormonal imbalances. Additionally, physical activity temporarily raises blood pressure, but regular exercise lowers it long term. Posture also affects blood pressure as it is usually lower when lying down and can increase when standing. Lastly, pregnancy may fluctuate the blood pressure, with some women experiencing higher readings due to increased blood volumes. Variations in blood pressure upon failure of regulatory mechanisms include hypotension, which is decrease in blood pressure below the value of 90 by 60 mmHg, and hypertension, which is increase in blood pressure above the value of 140 by 90 mmHg. These clinical conditions will be discussed further in detail by the Department of Pathology. Given here are some references used during our preparation. Now, I pass on the mic to my colleague representing the Department of Pathology to carry the presentation forward. Thank you.
Good morning, respected teachers. Today, I, Nishthha Sharma, along with my colleagues Krishna Bhargava, Pragyam Jindal, Swasti Chandak, and Tanish Gupta, under the moderation of Dr. Neeraj Goyal sir, and under the guidance of Dr. Manju Raghav ma'am, are going to be representing the Pathology department and presenting the topic Pathology and Pathogenesis of Hypertension. A sustained systolic pressure greater than 140 mm of mercury and a sustained diastolic pressure greater than 90 mm of mercury is characterized as hypertension. The staging of hypertension done by the ESH and ESC is as follows. Grade 1, Grade 2, and the third is hypertensive emergencies. As it has been previously discussed, the blood pressure is a product of cardiac output and peripheral resistance. There are various factors that influence these parameters. A change in these factors can lead to higher blood pressure, causing hypertension. This is the RAAS or renin-angiotensin-aldosterone system, which has been previously discussed and is an important regulatory mechanism in maintenance of normal blood pressure. Hypertension in the olden days was considered essential for normal human growth and elderly people. But now we know that it is neither essential nor benign. Hypertension is divided into two parts: primary hypertension and secondary hypertension. Primary hypertension is mainly idiopathic. its factors are not known. It is due to interaction of various genetic pleomorphs, lifestyle factors, and environmental factors. Secondary hypertension occurs due to an underlying primary pathological conditions, generally involving the renal system or the endocrine system. 90 to 95% of patients having primary hypertension and only 5 to 10% of patients have secondary hypertension. Etiology of primary hypertension. It is due to various genetic factors, lifestyle factors, vasoconstrictive influences, and racial factors. Genetic factors. Various familial aggregates and more than 60 different loci are seen to be individually contributing to a high blood pressure. Lifestyle factors such as living a sedentary lifestyle, eating a high sodium and saturated fat diet, living in stress, and chronic smoking can lead to hypertension. Vasoconstrictive influences. Many adrenergic receptors in our blood vessels cause its vasoconstriction or vasodilation, such as alpha-1 and beta-1 receptor for vasoconstriction and alpha-2 receptor and beta-2 for vasodilation. A balance in these factors cause the normal vessel tone, but maybe due to progress of age and the arteries losing their elasticity or due to a sympathetic outflow dysfunction, these vessels balance is lost and it can cause vasoconstrictive hypertension. Pathogenesis of essential hypertension. We've discussed the etiological factors and these factors interplay to dysregulate the sodium-water homeostasis. This leads to sodium and water retention in our body and causing the plasma volume expansion as well as the extracellular fluid volume expansion, which causes increase in cardiac output and in turn hypertension. Various factors such as increased sympathetic flow or activation of the RAAS system also leads to increased peripheral resistance, which causes hypertension. Etiopathogenesis of secondary hypertension caused by underlying conditions and is defined in renovascular hypertension, endocrine hypertension, single gene disorders, cardiovascular hypertension, and neurological hypertension. Renovascular hypertension includes diseases such as CKD or chronic kidney disease, especially when it affects the glomeruli, and renal artery stenosis. In renal artery stenosis, there is a constriction in the vessels taking blood to the kidney. This leads to a low perfusion in the kidney and in turn causes the activation of the RAS system, increasing the blood pressure. Endocrine hypertension. Diseases such as pheochromocytoma, Cushing syndrome, Conn's disease leads to dysregulation of the RAS system and also dysregulation of vasoconstrictive factors, causing hypertension. Single gene disorder, for example, Liddle syndrome. In Liddle syndrome, there is a gain in function mutation in the SCNN1B gene and SCNN1G gene, which causes a hyperactivity of ENaC receptors. This leads to increased sodium absorption in our body and causing sodium water retention, ultimately increasing the plasma volume and causing high blood pressure. Cardiovascular causes such as coarctation of aorta and polyarteritis nodosa are important factors for hypertension. Neurological factors such as sleep apnea, high intracranial pressures, or in patients in post-operative care, secondary hypertension is seen. Preeclampsia. Preeclampsia is a multi-system disorder characterized by high blood pressure, more than 140/190 mm of mercury, and proteinuria in a woman after 20 weeks of pregnancy who is not already hypertensive and proteinuric. The pathogenesis of preeclampsia is as follows. Normally, the trophoblastic cells invade the spiral arteries of the placenta and cause them to become flask-shaped. But in preeclampsia, the second wave of invasion is stopped, leading to decreased perfusion in the placenta and causing placental infarction. This leads to oxidative stress in placenta and also endothelial damage. It causes increase in anti-angiogenic factors such as SFLT1 and SENG. They cause vascular disruptions and removal of angiogenesis. They mainly affect 4 organs. First, kidney, second, liver, brain, and the vessels. In the kidney, they cause the spasm in the glomerular cells, which leads to decreased reabsorption of protein and leads to proteinuria. Various vasoconstrictive factors such as angiotensin II and vasodilative factors such as prostaglandins and sodium nitrium oxide are dysregulated in cases of preeclampsia, causing a high blood pressure. When there is a sustained increased pressure on the vessels in our body, it leads to morphological changes in them. These morphological changes are illustrated below. On the left-hand side is the histology of a normal vessel, whereas on the right-hand side we can see the morphological changes. The first is hyaline arteriolosclerosis. In this, there is a pink hyaline proteinaceous deposits in the intima of the vessel, causing narrowing of the lumen and in turn causing changes. The second is nephrosclerosis. Due to fibrotic deposition, the lumen of the arteries taking blood to the renal system get narrowed and leads to nephrosclerosis. Hyperplastic arteriolosclerosis. There is a characteristic onion skin appearance visible due to concentric lamination of smooth muscle cells. Pulmonary hypertension. In this, there is a characteristic intimal thickening and medial hyperplasia seen. So as to summarize, 90 to 95% of patient load in hypertension is idiopathic and we don't know the cause and hence it can't be cured completely. Secondary hypertension, which can be cured by curing the underlying pathological condition, but only accounts for 5 to 10% of the cases. Now, I pass the stage to Manshi from the Pharmacology department. Thank you.
A very pleasant morning to all the respected seniors, curious juniors, and my dear colleagues. Today I, Manshi Mahla, will give a presentation on the topic Pharmacological Management of Hypertension. I will be representing my team, including Harshit Yadav, Rakshita Gadia, Mehul Mishra, and Piyush Tiwari. The presentation was made under the guidance of Dr. Anusha Vora ma'am, Professor and Head, Department of Pharmacology, and under the moderatorship of Dr. Nishthha Sharma ma'am and Dr. Pushkar Mani sir. This will be the basic outline of our presentation today. We broadly classify antihypertensive drugs into 4 classes for our ease of understanding. All these 4 classes act by different mechanisms to achieve our goal of reducing the blood pressure. Firstly, we have the renin-angiotensin-aldosterone system inhibitors, which, as the name suggests, inhibit the RAS. Next, we have the sympatholytic drugs, which reduce the sympathetic outflow, the diuretics, which cause loss of sodium and water, and finally, the vasodilators. Starting off with the RAS inhibitors. One might ask, what makes them so special? Why are we starting with these? Well, as my colleague from the Physiology department has already shown us, RAS is implicated in hypertension, and thus any drug which inhibits the system at any level is an important antihypertensive. These include the angiotensin converting enzyme inhibitors, the angiotensin II receptor blockers or AT1 antagonists, the renin inhibitors, and the aldosterone antagonists. From this diagram, we will take a look at the mechanism of action of various RAS inhibitors. Firstly, the beta blockers act on the kidney and inhibit the release of renin, which is the first step in the RAS mechanism. Next, the renin inhibitors inhibit the action of already released renin and have a common suffix kirin, such as aliskirin, enalkirin, etc. Moving on in the axis, we have the ACE inhibitors, which inhibit the action of the angiotensin converting enzyme released from the endothelial cells of the lung capillaries. Next, we have the angiotensin 2 receptor blockers, which inhibit the actions of angiotensin 2 by blocking the AT1 receptors. And finally, the aldosterone antagonists. These inhibit the action of aldosterone, which is a potent mineralocorticoid and causes sodium and water retention. The examples are spironolactone and eplerenone. While spironolactone causes hormonal side effects such as gynecomastia, there are no such side effects seen with eplerenone. ACE inhibitors have a common suffix pril, such as lisinopril, enalapril, ramipril, etc. These are indicated in hypertension, congestive heart failure, diabetic nephropathy, and since these are also cardioprotective, they are useful in left ventricular dysfunction. Some side effects such as dry cough are seen due to inhibition of bradykinin metabolism, and in general, all the RAS inhibitors have a common constellation of side effects including angioedema, hyperkalemia, rashes, and teratogenicity. ACE inhibitors and ARBs have common contraindications such as bilateral renal artery stenosis, pregnancy, and hyperkalemia. The ARBs have a common suffix sartan, such as losartan, olmesartan, telmisartan, etc. And their indications are more or less similar to that of the ACE inhibitors, but these are preferred in patients of concurrent diabetes mellitus and hypertension, since these reverse the insulin resistance, and also preferred in patients who develop dry cough due to ACE inhibitor therapy. Our sympathetic system is activated in fight, flight, and freeze situations and is responsible for increasing our blood pressure. The sympatholytic drugs inhibit the sympathetic outflow and thus reduce the blood pressure. These include alpha blockers, which can be non-selective, or selective alpha-1 blockers, such as prazosin, the beta blockers, which can be non-selective like pindolol, and cardioselective beta blockers, such as metoprolol and atenolol. We prefer the cardioselective beta blockers since these don't cause side effects such as asthma and peripheral vascular disease. Next, we have the combined alpha and beta blockers, such as labetalol, useful in pregnancy. The centrally acting sympatholytics or alpha-2 agonists are clonidine and alpha-methyl-dopa, whereas the adrenergic neuron blockers are not used nowadays in hypertension. Let's take a look at the site of action of various sympatholytics. The central sympatholytics act on the alpha-2 receptors in the brain. Now one might ask, why are we talking about agonists here since we're talking about sympatholytics? Well, the alpha-2 receptors are autoreceptors present presynaptically, and their stimulation causes decreased sympathetic outflow. Next, we have the beta blockers which act on the heart and the kidney to reduce sympathetic outflow, and the alpha blockers which act on the alpha-1 receptors in the blood vessels causing vasodilation. Alpha blockers such as prazosin are used in concurrent hypertension and benign prostatic hyperplasia in elderly males. And since these cause postural hypertension, we always start with a low dose, and while prescribing these, we advise the patient to take the drug at night time just before bed and to not stand up suddenly. Instead, to take your time, first sit slowly and then stand up. Beta receptors cause vasodilation, and following that, beta blockers must cause vasoconstriction. Then why are we using them in hypertension? Well, the beta blockers have an entirely different mechanism of action. They act on the heart to give negative chronotropic, inotropic, and bromotropic effects. And on the kidney, they act on the juxtaglomerular cells to inhibit renin release and thus reduce the sympathetic outflow. These are indicated in hypertension, arrhythmias, angina pectoris, prophylaxis of migraine, etc. The mnemonic for side effects is bad fish. One important side effect to always be kept in mind is that beta blockers mask the signs of hypoglycemia in diabetic patients. Thus, while prescribing them to a diabetic patient, we must advise them to be vigilant about sweating since this is the only remaining sign. The contraindications can be remembered by A, B, C, D. The centrally acting sympatholytics or the alpha-2 agonists, such as clonidine, are useful in hypertension, migraine prophylaxis, and opioid withdrawal, whereas alpha-methyl-dopa is useful in preeclampsia. On sudden cessation of clonidine, a phenomenon of rebound hypertension or clonidine withdrawal occurs due to the upregulation of alpha-2 receptors causing supersensitization. These are contraindicated in depression, heart block, pregnancy, etc. The next class of drugs we'll talk about is the diuretics. These can be classified into the thiazides, the loop diuretics, and the potassium-sparing diuretics. In hypertension, we mainly use the thiazides and the loop diuretics, since these cause loss of sodium in water, and potassium-sparing diuretics are mainly used as adjuvants to stop side effects such as hyperkalemia. Thiazides like hydrochlorothiazide act on the early distal tubules, and inhibit the sodium chloride symport, thus reducing sodium in water and causing hypovolemia. But our compensatory mechanisms come into play and revert the blood volume back to normal. Despite this, some sodium deficit remains, which is the cause for the reduced blood pressure and reduced rigidity of the vessel walls. These are long-acting and low-staining diuretics preferred in hypertension, while loop diuretics like furosemide are short-acting and high-sealing and useful in left ventricular hypertrophy. Thiazides and loop diuretics have similar side effects, but they differ in one, that is calcium. While the thiazides cause hypercalcemia, loop diuretics cause hypocalcemia. This can be remembered by the mnemonic, loop loses calcium. Thiazides are indicated in hypertension, diabetes insipidus, while the loop diuretics are useful in hypertensive emergencies, left ventricular failure, etc. The contraindications are similar, namely gout, severe renal failure, pregnancy, etc. Finally, we come to the vasodilators. These can be classified into the L-type calcium channel blockers, which are further divided into three classes chemically: the dihydropyridines, such as amlodipine, the phenylalkylamines, and the benzothiazepides. The latter two are centrally acting CCBs useful in angina, while the dihydropyridines are useful in hypertension. Next, we have the potassium channel openers, such as minoxidil and diazoxide. Minoxidil causes hirsutism, that is, male pattern hair growth in females, and is now used to treat alopecia. And finally, we have the nitric oxide releasing drugs, namely sodium nitroprusside and hydralazine. These cause release of nitric oxide, or the endothelium-derived relaxing factor from the endothelial cells, which causes vasodilation. Sodium nitroprusside is a fast-acting antihypertensive useful in emergencies, and its long-term usage, that is more than 72 hours, is contraindicated since it causes cyanide poisoning. Hydralazine has dual antihypertensive actions. It's a nitric oxide releaser as well as a potassium channel opener. The calcium channel blockers inhibit the opening of the L-type calcium channels in the myocardium and the blood vessels, causing vasodilation and negative chronotropic and ionotropic effects. Dihydropyridines like amlodipine are indicated in hypertension, arrhythmia, angina, etc. and their major side effect is pedal edema. These are contraindicated in AV block, heart failure, severe hypertension, etc. Coming on to the drug combinations used in hypertension. Now, whenever a patient comes to the OPD with hypertension, we must always first prescribe lifestyle modifications like DASH diet and exercising before starting with any medication. One thing I'd like to point out is that hypertension is a chronic disease, and once the medication for it starts, it continues lifelong. According to the 8th guidelines of the Joint National Committee, we must adopt a stepped care approach. That is, when we start medication with any first-line drug, we start with a low dose and increase the dose according to need and response of the patient up to a limit, following which we add another hypertensive from another class with a different mechanism. We must use rational combinations, that is drugs which have a supra-additive or synergistic response. One thing to remember is that we must avoid the usage of two drugs of the same class, since the side effects add up and no clinical benefit is seen. Now, what's the difference between hypertensive emergency and urgency? While both of these have similar blood pressure ranges, which is more than 220 by 120 mmHg, there is a significant difference. In emergency, we have clear-cut evidence of target organ damage, while no such damage is seen in urgency. Accordingly, the pharmacotherapy differs. In emergency, we need to reduce the BP within minutes, so we use the IV infusion of labetalol, nicardipine, nitroprusside, etc. While in urgency, we use oral therapy over 2 to 48 hours with labetalol, amlodipine, etc. The criteria for gestational hypertension is a sustained BP reading of over 140 by 90 mmHg during pregnancy. Most of the drugs are teratogenic. Most of the antihypertensive drugs are teratogenic, as can be seen on the screen, and thus contraindicated. Teratogenic drugs cause fetal malformations and congenital anomalies in the fetus, and therefore these are contraindicated. Some safer options are labetalol and alpha-methyl dopa. Finally, here are some points to remember and take home with you. The first line drugs are A, C, D. A for the ACE inhibitors and ARBs, C for the CCBs, mainly dihydropyridines, D for the diuretics, mainly thiazides. In hypertensive emergencies, our drug of choice is nicardipine, and in case of gestational hypertension, we use oral labetalol or alpha-methyl dopa. But in case of emergency or eclampsia, we use IV labetalol with added magnesium sulfate for seizures. And finally, in resistant hypertension, where the desired fall in BP is not occurring, even with all three classes of first-line drugs, we use pyranolatol. On behalf of all the presenters and the teammates, I thank you all for being an attentive and eager to learn audience.